Okay, good afternoon. So we will have the rest of our OB case report for this afternoon. So Christian, you may start with your presentation.
Okay pa, Doc.
Okay, good afternoon. So we will have the rest of our OB. Ba't gano'n nagpapaulit-ulit? Okay na, Christian? What
Okay pa, Doc.
happened? Ba't mo ulit-ulit? Anyways, sige. Let's start.
Okay pa, Doc. Good afternoon, doctors. My name is Christian Platon, and I'll be discussing the first case for this discussion po. So, this is the case of AS, a 43-year-old female Filipino, married, admitted for the first time in this institution last May 14, 2021. So the patient was the informant during the interview. Patient came in into this institution due to prolonged and heavy menstrual bleeding. So for the history of present illness, 1 year prior, patient was apparently well until 2 years prior to admission. Patient noted an increase in her menses with noted prolonged and heavy bleeding amounting from the normal 4 pads down to 10 moderately soaked pads per day. And the said episode lasted for 3 weeks. I sorry. Uh, The said episode lasted for 3 weeks. There were no associated weakness, headache, dizziness, abdominal and flank pain, nausea, vomiting, and no consult was done, no medications were taken. Wait po. Sorry po, naglalag po yung computer ko. Sorry. Restart ko lang po yung yung PowerPoint, sorry.
Sige, okay lang.
And then 1 month prior, sorry, not this one. 1 year prior to admission, patient noted persistence of menses with prolonged and heavy bleeding, now amounting to 10 moderately soaked night pads per day. The said episode lasted for 3 to 4 weeks with approximately 1 week interval of no bleeding. There were no associated signs and symptoms noted. Consult was done with an general practitioner and was advised transvaginal ultrasound and a referral to OBGYN. Patient was also prescribed with an unrecalled medication which offered temporary symptomatic relief. Patient was lost to follow up thereafter. In the interim, there was persistence of the bleeding with no other signs and symptoms noted. No consult was done, but an unrecalled herbal medication was taken, which offered slight symptomatic relief according to the patient. So 1 month prior to admission, patient noted excessive bleeding amounting to 1 to 2 moderately soaked diapers per day, with mucoid blood clots noted, non-foul smelling. There was associated weakness and a hypogastric pain characterized as crampy, localized, 7 out of 10 in pain scale. This led to a consult at a private OBGYN clinic for assessment and management. An ultrasound was done revealing a thickened endometrium and unilocular thin-walled cyst on the left ovary. Um, Patient was given tranexamic acid, 500 milligrams per tab, one tab, 4 times a day for 7 days, which offered temporary symptomatic relief of the bleeding. Patient was advised admission for a contemplated dilatation in curettage and was eventually admitted on the scheduled date. So the patient's LMP and PMP were noted to be last to 2019 with unrecalled dates. So for the OB/GYN history, for the menstrual history, the patient's menarche was during when she was 12 years old with 4 to 5 days duration, amounting to 4 moderately soaked normal pads on the first to second day with associated dysmenorrhea, occasional, and no medications were taken. So subsequent menses, on the other hand, were irregular, occurring at 5 to 7 days of interval with 21 to 25 days duration, 10 fully amounting to 10 fully soaked pads to 1 to 2 moderately soaked diapers with blood clots noted and associated dysmenorrhea. For the OB history, the patient is Gravida 3, Para 3, 3003. For G1, Gravida 1, G1 was born on 2000 at a public institution delivered via NSD to a live-term baby boy with no complications. Birth weight was unrecalled. So Gravida 2, on the other hand, was born in 2002 at a public institution delivered via NSD to a live-term baby boy with no complications. Birth weight was unrecalled. And lastly, Gravida 3 was born on 2004 at a lying-in clinic delivered via NSD to a live-term baby girl with no complications. Birth weight was unrecalled. So for the gynecologic history, there were no noted gynecologic illness, operation, or malignancy noted. No pap smear was done before and no HPV vaccine was given. It is important to take note that the patient did not underwent through hormonal therapy. And for the sexual history, Coitor Q was around 18 years old with no noted bleeding or dyspareunia. Subsequent contacts were comfortable with no associated bleeding and pain. Patient had one sexual partner and last sexual contact was unrecalled. There were no sexually transmitted infection exposure or treatment and no history of trauma. So for the past medical history, patient was diagnosed with hypertension last 2018 and losartan 50 milligrams per tab once a day and amlodipine 10 milligrams per tab once a day before bedtime was her maintenance medication. She was also diagnosed with hyperthyroidism last 2018 of the same year with methimazole 20 milligrams per tab once a day as her maintenance. There were no noted bleeding disorders, diabetes, no heart disease, cardiovascular disease, asthma, allergies, pulmonary tuberculosis, and malignancy noted. There were no prior hospitalization no surgical procedure done to the patient before. So for the family history, there was a unrecalled malignancy on the maternal side of the family. No thyroid disease, familial thyroid disease noted, no familial bleeding disorders, no twinning, difficult labor, and congenital anomalies noted. For the social and environmental history, our patient works at a BPO company, was said to have a sedentary lifestyle with poor diet, is an overweight with a BMI of 29, is a smoker, and an occasional alcoholic beverage drinker. Patient is married for 21 years and her husband works as a liaison officer. So for the review of systems, it is noted that the patient had weakness and no epistaxis noted. There were also no bruises, no petechiae, and no hematoma. For the physical exam, it is important to take note that the blood pressure of the patient was high at around 160 over 110 millimeters mercury. Patient also was overweight with the BMI of 29. Upon assessment of the skin, patient had pallor, and upon assessment of the HENT, patient had pale palpebral conjunctiva. For the genitalia, there was a noted vaginal bleeding. Unfortunately, speculum examination and internal examination weren't done because the patient refused. And Upon checking the extremities, they were full and equal bipedal pulses and pale nail beds with a capillary refill of more than 2 seconds. So for the subjectives of this case, we have AS, a 43-year-old female who is married with a history of prolonged and heavy menses amounting from 4 to 10 pads up until 2 diapers, moderately soaked with noted blood clots and associated weakness and hypogastric pain. Her subsequent menses were irregular with 5 to 7 days of interval and 21 to 25 days of duration. Um, she is a Gravida 3 Para 3 3003, did not undergo hormonal therapy, no exposure to STI or treatment, was diagnosed to have hypertension and hyperthyroidism, no bleeding disorders or diabetes, no familial bleeding disorders, was noted to have family history of unrecalled cancer on the maternal side with sedentary lifestyle and poor diet, was an overweight with a BMI of 29, a smoker, and an alcoholic beverage drinker. For my objectives, the patient was conscious, coherent, and not in cardiopulmonary distress. Her blood pressure is high and the cardiac rate is normal. Uh, the patient has a BMI of 29. Her skin was, she has pallor, pale palpebral conjunctiva with noted vaginal bleeding. Speculum exam and internal exam were not done. And on the extremities, she has full and equal pedal pulses, pale nail beds, and a capillary fill time of more than 2 seconds. For the admitting diagnosis, we have Gravida 3 Para 3 3003, abnormal uterine bleeding, ovulatory malignancy, with mild anemia secondary to chronic blood loss, hypertension stage 2, hyperthyroidism, and euthyroid state. So for the plan, the patient was set to have her dilatation and curettage once CP cleared. For the discussion of abnormal uterine bleeding, we will be dividing it into four approaches. First is the introduction, next is the AUB classification, third is the diagnostic, and lastly is the management. For my references, I have the following books. So, abnormal uterine bleeding is one of the most common health concerns of women, and it can present in many ways, such as infrequent episodes to excessive flow. As a review, the mean duration of menstrual cycle is around 28, give or take 7 days. And the average menstrual blood loss or MBL is around 35 ml, with a normal value of around 10 to 80 ml. And the average number of days of menses is around 4 days with a normal range of 2 to 7 days. So bleeding is noted to be abnormal or heavy if it occurs at intervals of 21 days or less or 35 days or more, and it lasts longer than 7 days and has a menstrual blood loss of 80 ml or greater. So dysfunctional uterine bleeding is no longer favored term and should be discarded. So for the classification of AUB, we have the palm coin. For the palm, it's more of structural, and for the coin, it's more of non-structural. We will focus on our case, which is malignancy and ovulatory dysfunction. So before we start the discussion on the different subclassifications, for the nomenclature of AUB, the acronym AUB is followed by the letters palm coin and a subscript of 0, meaning absent, or 1, meaning present. Uh, so for our case, the patient has AUB with a subscript on the M and on the O. So for AUBM or malignancy, it involves the vulvar, vaginal, cervical, endometrial, uterine, and adnexal cancers. And bleeding from cervical malignancy classically presents as coital bleeding or intermenstrual bleeding. It is mostly secondary to prolonged exposure to hyperestrogenic states such as chronic anovulation, PCOS, obesity, nulligravity, and other conditions. It is important to take note of Lynch syndrome, which is a hereditary non-polyposis colorectal cancer. It is a autosomal dominant disease caused by a disruption in in the mismatch repair or MMR genes, and it carries a 40 to 50% lifetime risk of endometrial cancer, mostly before the age of 45. Estrogen-producing ovarian tumors, such as granulosa T cell tumors, may also present as may also cause AUB. Ovulatory dysfunction, on the other hand, is the predominant cause of ovulatory uh, is secondary to alterations in the neuroendocrine function. So there is a continuous estradiol production without corpus luteum formation and progesterone production, leading to a continuously proliferating endometrium, which may outgrow its blood supply, leading to necrosis. The uniform slough to the basalis layer does not occur, leading to more excessive uterine bleeding. So, anovulatory bleeding occurs most commonly during the extremes of reproductive life in the first few years after menarche and during perimenopause. So, in adolescence, anovulation is due to an immaturity of the hypothalamus pituitary ovarian axis or HPO and the failure of positive feedback of estradiol LH surge. On the other hand, in perimenopausal women, as they approach ovarian decline at menopause, there begins a lack of synchronization between the components of the HPO axis. So patterns of ovulatory bleeding may be oligomenorrhea, intermenstrual bleeding, or heavy menstrual bleeding. And causes of anovulation are the following: so it's extreme of reproductive life, polycystic ovarian syndrome, hypothalamic
Christian?
sorry, Doc,
Yun lang.
disconnect
Okay.
po ako. Sorry, mabagal po yung internet ko.
Okay
Share ko
lang.
po ulit.
Okay lang.
Kita na po yung screen ko po.
Go ahead.
Okay po. So, causes of anovulation are the following: extremes of reproductive life, polycystic ovarian syndrome, hypothalamic dysfunction related to weight loss, severe exercise, stress or drug use, and abnormalities of other non-reproductive hormones such as thyroid hormone, prolactin, and cortisol. So for the diagnostic approach for patients with AUB, for the medical history, a detailed menstrual history is important. We should take note of the frequency, duration, and amount of bleeding, inquire whether and the menstrual pattern change. We should also take note and describe the menstrual abnormality as oligomenorrhea, polymenorrhea. So symptoms present for the majority of the preceding 6 months are considered chronic. In menstrual history, we should ask our patients, for all patients, the age at menarche, the cycle length, the duration of bleeding, perception of flow, menstrual product use, first day of LMP, and dysmenorrhea. So for patients reporting heavy menstrual bleeding, we should take note that it should have lasted for more than 7 days. It soaks through pads or tampons for 1 hour for 2 to 3 hours in a row, require frequent pad or tampon changes, soaking more than one every 1 to 2 hours, passing blood clots more than or equal to 1 inch in diameter, and using double protection, such as a pad plus a tampon or 2 pads used altogether. So there should also be a flooding or gushing sensation, frequent accidents or leaking through protection, hemorrhage from a corpus luteum, diagnosis with anemia, and a associated history of excessive bruising or bleeding, or a family history of bleeding disorder. So for patients reporting personal history of more than or equal to one of the following symptoms, such as epistaxis, spontaneous bruising or minor wound bleeding, bleeding from the oral cavity or GI tract without an obvious anatomic lesion, prolonged excessive bleeding after dental extraction or surgery, and hemorrhage that required transfusion. So for the past medical history, we have to take note of the uh, systemic illness, including hematologic or renal disease, current or recent medications as well. For the family history, we have to take note of the bleeding disorders, menstrual disorders, diabetes, and thyroid diseases that are diagnosed in the family. And for social history, we have to take note of social stressors, substance use, exercise patterns, and athletic competitions, as this could affect the hormonal balance of the patient. So for the sexual history, we should take note of the contraception and condom use, the number of partners, history of sexually transmitted infections or current symptoms, previous pregnancy or abortion, and a history of sexual abuse or assault. For the physical examination, in the vital signs, tachycardia and hypertension can lead to acute hemodynamics instability and the need for rapid intervention. The presence of tachycardia, pallor, or heart murmur suggests anemia. Petechiae or excessive bruising suggests a platelet defect or another bleeding disorder, whereas obesity, acne, hirsutism, acanthosis nigricans may be present in a patient with PCOS. So palpation of the thyroid gland for enlargement or other abnormalities should be done, as well as an examination of the optic fundi and visual field testing for cases with pituitary tumor. So sexual maturity rating of the breasts and assessment of galactorrhea should also be considered in sellar or suprasellar tumors. And palpation of the abdomen may be done to check if there is current pregnancy or a uterine or ovarian mass. So external inspection of the genitalia is sufficient for diagnosis in most patients. And sexually active patients may warrant a complete pelvic examination, such as speculum and bimanual exams. So for the laboratory and diagnostics, we can also order pregnancy tests to exclude pregnancy, a complete count, including differential and platelet count, blood typing to check whether the patient has anemia, as well as a measure of iron source. Prothrombin time and activated partial thromboplastin time may also be checked for bleeding disorders. Von Willebrand studies such as factor 8, uh, VWF antigen, and ristocetin cofactor may be, uh, may be ordered when indicated for coagulation disorders. A thyroid function test such as the TSH may be ordered for excluding thyroid diseases, and tests for uh, chlamydia trachomatis and Neisseria gonorrhoeae may be ordered for sexually active patients. Pelvic ultrasound is the best initial diagnostic tool. Lastly, in patients with history of amenorrhea or irregular bleeding prior to the onset of heavy bleeding, we can order for FSH and LH for abnormalities and imbalance, a total and free testosterone levels, dehydroepiandrosterone, and prolactin level to check for prolactinemia. For the treatment, the management of AUB depends on the assessment of whether or not the patient is hemodynamically stable, for the determination of the underlying cause, and medical management is based on etiology and the severity of anemia. The goals of treatment are to establish and or maintain hemodynamic stability, correct acute or chronic anemia, return to a pattern of normal menstrual cycles, prevention of recurrence, and prevent long-term consequences of anovulation. So the goal of medical therapy is to primarily stabilize the endometrium with estrogen, thereby providing initial hemostasis, followed by progestins, which lead to endometrial stability. It is achieved with combined oral contraceptive pills or OCPs taken continuously for several months until hemodynamically stable. So withdrawal of either hormone will cause recurrent bleeding, and episodes of moderate to severe bleeding are treated effectively with frequent dosings of combined oral contraceptive pills. So in the absence of an organic cause of excessive uterine bleeding, it is preferable to use medical instead of surgical treatment, especially if the woman desires to retain her uterus for future childbearing or will be undergoing natural menopause within a short time. So the type of treatment depends on whether it is used to stop an acute heavy bleeding or it is given to reduce the amount of menstrual blood loss in subsequent menstrual cycles. So take note that a definitive diagnosis is required before instituting long-term treatment and should be made on the basis of hysteroscopy, sonohysterography, or directed endometrial biopsies. So for the specific treatment of AUBO in adolescents, after ruling out coagulation disorders, the main direction of the therapy is to temporize because once the HPO axis matures, the problem will be corrected. So we can give cyclic progestogen to produce reliable and controlled menstrual cycles. Oral contraceptive may be an option if the problem persists beyond 6 months. For perimenopausal women, we can give low-dose combined oral contraceptives in non-smoking women and cyclic progestogens. And in reproductive age women, we can give combined oral contraceptives and cyclic progestogens as chronic anovulatory bleeding is primarily caused by hypothalamic dysfunction or PCOS in such ages. We can also give NSAIDs, which are prostaglandin synthetase inhibitors that inhibit the biosynthesis of cyclic and endoperoxides, which convert arachidonic acid to prostaglandins. They block the action of prostaglandins by interfering directly at the receptor sites. As all NSAIDs are cyclooxygenase inhibitors and thus block the formation of both thromboxane and the prostacyclin pathway, it is shown to reduce menstrual blood loss primarily in women who ovulate. So some drugs given in the first 3 days of menses or the whole duration of bleeding can be a mefenamic acid, ibuprofen, and naproxen sodium. Antifibrinolytic agents such as epsilon aminocaproic acid or EACA, tranexamic acid, and para-aminomethylbenzoic acid are potent inhibitors of fibrinolysis. Uh, Unfortunately, their use is somewhat limited by side effects, as many GI side effects can be minimized by reducing the dose and limiting therapy to the first 3 to 5 days of bleeding. Uh, Due to the increased risks of thrombosis and myocardial infarction, antifibrinolytic agents should not be combined with oral contraceptives. Combined treatment with tranexamic acid and the oral contraceptive pill has been implicated in coronary ulcerated plaque and acute myocardial infarction. For gonadotropin-releasing hormone agonists, GnRH agonists may be used to inhibit ovarian steroid production as estrogen production is necessary for endometrial proliferation. So because of the expense and menopausal side effects of these agents, their use is somewhat limited to women with severe menstrual blood loss who fail to respond to other methods of medical management and wish to retain their childbearing capacity. So more commonly, GnRH agonists are an effective means of bridging patients to surgical treatment, allowing for correction of anemia. Use of an estrogen or progesterone or ADVAC therapy together with the agonist will help prevent bone loss. So in the management of acute AUB, in women who are bleeding heavily and are hemodynamically unstable, the quickest way to stop acute bleeding is with curettage. Curettage should also be the preferred approach for older women and those with medical risk factors for whom high-dose hormonal therapy may pose a great risk for their condition. And they may also be medically managed. So some pharmacological agents for acute bleeding, to stop acute bleeding that does not require curettage, the most effective regimen involves high dose estrogen, as high dose estrogen is aimed at stopping acute bleeding and is a merely temporary measure. So for estrogens, it causes a rapid growth of the endometrium, and it occurs over the denuded and raw epithelial surfaces. Large doses of estrogen may alter platelet activity, thus promoting platelet adhesiveness. Oral conjugated equine estrogen or CEE may be given as well as an IV conjugated estrogen and combination oral contraceptive. Progestogens can be given for patients with no indication to estrogen, not only to stop endometrial growth, but also support and organize the endometrium so that an organized slough occurs after their uh, withdrawal. So organized slough to the basalis layer allows a rapid cessation of the bleeding. And progestogens also stimulate arachidonic acid formation in the endometrium, increasing the PGF2-PGE ratio. We can give medroxyprogesterone acetate, depo-MPA, and norethindrone acetate. Androgen such as danazol is a synthetic androgen used in doses of 200 milligrams daily for the treatment of heavy menstrual bleeding. It is limited. It is used in limit because of the side effects of weight gain and skin problems. So for the surgical management of acute AUB, dilatation and curettage can be both diagnostic and therapeutic. In the immediate management of severe bleeding. It is the treatment of choice in hypovolemic women and may be preferred as an approach to stop an acute bleeding episode in women older than 35 when the incidence of pathologic findings increases. It is only indicated for women with acute bleeding resulting in hypovolemia and for older women who are at higher risk of having endometrial neoplasia. All other women, after having an endometrial biopsy, sonohysterography, or diagnostic hysteroscopy to rule out organic disease, are best treated with medical therapy without DNC. Next, we have endometrial ablation. It is done if medical therapy is not effective or is contraindicated. With exceptions are women who have a very large uteri caused by fibroids or abnormal pathologies such as endometrial hyperplasia or cancer, and is an alternative to hysterectomy. Um, Lastly, for the surgical management of acute AUB, we have hysterectomy, which is the surgical removal of the uterus. It is reserved for the women with other indications for hysterectomy, such as leiomyoma or uterine prolapse. It is usually offered to women with completed family size and no longer desirous of pregnancy. And it is used to treat persistent abnormal uterine bleeding after all medical therapy has failed or medical therapy is contraindicated. So for the management of chronic AUB, there are multiple treatment options available for treatment of chronic AUB, such as levonorgestrel intrauterine system oral contraceptives, progestin therapy, which are oral or intramuscular, tranexamic acid, and NSAIDs. That ends my presentation. Thank you for listening.
Okay. So AUB is quite common gynae complaint that you will encounter in your outpatient and even your admission, although most of it cannot undergo management as when surgery is concerned and would often end up in charity. Okay, but more often it's either patient is not bleeding or patient is bleeding excessively, bleeding more often than usual or less than usual. And the problem is with most Filipinos and Filipino women would be their health-seeking behavior. And what is this? 2 years na. No menstruation, saka lang naisipang magpa-check up. And it does happen. Sabi ko, when you ask, 2 years, bakit hindi nagpa-check up? Di ka ba nagtaka 2 years, hindi ka nireregla? What's the common answer? Either natatakot, afraid to So in this case, what was your final diagnosis? And what happened to the patient eventually?
Doc, the final diagnosis was AUB ovulatory po.
AUB ovulatory. And that's one of the hardest things to diagnose. Why is that? You have to rule out everything before you could conclude that it is just an ovulatory problem. And that includes your anatomic, endocrine, etc., etc., etc. Your gamut causes of abnormal uterine bleeding. Okay? So what was the management for this patient? Ovulatory. Ay, ovulatory lang. So what do we do?
Doc, we treat the underlying cause po.
And in this case,
Doc, it was more of her uncontrolled hyperthyroid state po.
so if it's hyperthyroid, there would be a cause of your abnormal uterine bleeding, and you have to manage it as such. You have to control your thyroid um, hormones such that you could um, manage the patient adequately. Okay? Why is that so? Why would your thyroid, why would your diabetes be related disorders? Why are they all related? What's the pathophysiology of that? Bakit sila magkakasama? Pag nagkaroon ng problem with one, more often than not, the others affected as well.
Doc, because it's most likely because of the imbalance po of the HPO axis po.
Imbalance of the HPO axis. What else? What could explain why thyroid, diabetes, and your ovarian problems would be interrelated? Where would it function? Where is it produced? And what is its structure? So it's interrelated because it's all found in your pituitary axis, such that when you just menstruated, your HPO axis is still immature. When it does mature, its hormones are interrelated such that its subunits are similar, and it just differs in one alpha, in your one beta subunit, but it's structurally similar such that when it sends signals and something goes wrong, more or less one is affected by the absence or excesses of the hormones present. Hence, your AUB is more often interrelated with your thyroid, your diabetes, etc., etc. Okay? Who wants to go next? So, good report, Christian. Even if we're getting
Thank
cut
you po,
off,
Doc.
pangit ng
Sorry
internet,
po,
but
Doc.
that's fine. It's okay.
Opo.
Who wants to go next?
Good afternoon po, Doc. Ako po yung next.
Go ahead, Winona. Okay.
Kita na po yung
Go
slide.
ahead.
Okay, good afternoon, everyone. I'm intern Rongavilla Winona, and I'll be and my case presentation is focused on post-menopausal bleeding. So, to begin, gumagalaw po ba yung slide? Parang,
Hindi. Hindi siya umaandar.
wait lang po. Ayan. I think gumagalaw na po yung slide. Tama po ba? Gumagalaw na po yung slide. Gumagalaw na po yung slide ko? Or nag-change na
slide
siya?
ka na.
Okay. So, to continue, this is a case of a 68-year-old married with 4 children housewife who came in with the chief complaint of post-menopausal bleeding. For her past medical history, she is a known hypertensive for more than 20 years, maintained on losartan 50 milligram tablet, pilodipine 5 milligram tablet, metoprolol 50 milligram tablets, all of which she takes 1 tablet per day. And recently, she was diagnosed with diabetes mellitus this 2021, where she started maintenance medication of glycoside 50 milligram per tablet, which she takes a half tab per day. So she has no other previous surgery except for a previous cesarean section for breech presentation, which bilateral tubal ligation was also done. So she has no known allergies, and her family medical history is hypertension and bronchial asthma, both of which are from her maternal side. So she is a non-smoker, non-alcoholic beverage drinker, a housewife, and has been married for 46 years to a 68-year-old retired military personnel. For her gynecologic history, at the time of consult, sexual history was not probed since the patient felt uncomfortable to be questioned regarding this with her husband in the room daw po. Her pap smear was done in 2021, just recently, and had unremarkable results. She has no history of oral contraceptive use, and menopause started at 48 years old. For her obstetric history, she is a G5P5 5004 with four of her children. So G1 to G4 was born full term via spontaneous vaginal delivery, all of which had no fetal-maternal complication, and um, her G5 was also born term but was delivered via cesarean section for breech presentation. So her history of present illness started 2 months prior to admission, where the patient noted vaginal spotting using 3 lightly soaked panty liners per day, which lasted for 1 week. The patient did not note any associated symptoms like hypogastric pain or any bowel movement changes, so she did not seek consult nor did she take any medication. So 7 weeks prior to admission, she noted that the vaginal spotting persisted, which then prompted consult with a gynecologist from a different institution. At the time of consult, a pap smear was done, which revealed unremarkable results, and a transvaginal ultrasound was also done, which revealed slightly enlarged anteverted uterus with an echogenic mass measuring 3.4 by 2.7 by 4.7 centimeters, which could represent an old myoma with calcifications or an endometrial hyperplasia. So at that time, she was given unrecalled medication, which she took for 3 to 4 days. So following that, 6 weeks prior to admission, she went to the follow up. She went to follow up with that gynecologist with the transvaginal ultrasound result. She was advised to undergo dilatation and curettage, but at the time, due to the COVID-19 surge, she was lost to follow up until 5 weeks prior to admission, where the patient noted one episode of vaginal bleeding, which she used one moderately soaked pad, and she also noted blood clots. But similarly, there was no associated symptoms like hypogastric pain or bowel movement changes. So this prompted consult and subsequent admission in a different institution for dilatation and curettage. So the dilatation and curettage was done with the patient tolerating the procedure well, and she was prescribed tranexamic acid as needed for vaginal bleeding as home medication. So 4 weeks prior to admission, histopathology results revealed endocervical polyp, endometrial adenocarcinoma, endometrioid type well differentiated. So at the time po, she did not follow up with her initial gynecologist when she received the histopathology result. Rather, she was referred to the current attending physician now, but she did not seek immediate consult po with the reasoning of the COVID-19 surge po at the time. So until 1 week prior to admission, where the patient experienced recurrence of vaginal spotting, when she self-medicated with tranexamic acid as previously prescribed to her, which she only took for 1 day. So this episode prompted consult in our institution, where she was advised admission and subsequent uh, uh, where she was advised admission once she was CP cleared and COVID-19 RT-PCR negative. So at the time, she was admitted with the diagnosis of G5P5 5004, endometrial adenocarcinoma, endometrioid type, well differentiated, and the cervical polyp, hypertension stage 2, diabetes mellitus stage 2, previous low transverse cesarean section for breech presentation with bilateral tubal ligation. So the plan for the patient was to undergo total abdominal hysterectomy with bilateral salpingo-oophorectomy with bilateral lymph node dissection. So to begin the discussion, first, First, menopause refers to a point in time that follows 1 year after the complete cessation of menstruation. Thus, the postmenopause describes the years following after. So, in cases of postmenopausal bleeding, this refers to any uterine bleeding in a menopausal woman, other than the expected cyclic bleeding that occurs in women taking cyclic postmenopausal hormone therapy. So postmenopausal bleeding can be due to a lot of things. It has different etiologies. Namely, the most common one would be atrophy, where there is lack of estrogen, this which causes the atrophy of the endometrium. So inside the uterus, we would see a collapsed and atrophic surfaces of the endometrium contain scant or no fluid to that would prevent the friction inside the cavity. So this friction would lead to microerosions of the epithelial surface, which would then lead to chronic inflammation, and this chronic inflammation would be prone to developing spotting or light bleeding. Another etiology of postmenopausal bleeding is cancer, which often arises from unopposed estrogen, with the risk of endometrial cancer in the setting of postmenopausal bleeding increases with increasing age after menopause. So another common cause of perimenopausal or early postmenopausal uterine bleeding are polyps, which are benign endometrial growths that can be stimulated by estrogen therapy or by tamoxifen use. Another set of etiology of postmenopausal bleeding is postmenopausal hormone therapy. So, depending on the regimen used, many postmenopausal women who take estrogen therapy develop vaginal bleeding. Another is endometrial hyperplasia, which may manifest clinically as uterine bleeding, since postmenopausal women should be estrogen deficient. And endometrial hyperplasia at this time would be considered abnormal. So this may be due to endogenous estrogen production from ovarian or adrenal tumors, or due to conversion of um, androstenedione to estrone, or the aromatization of androgens to estradiol, which occurs in the peripheral adipose tissue. So other herbal and dietary supplements may also cause postmenstrual bleeding, with soy and other phytoestrogens in large doses may be associated with stimulation of the endometrial lining. So in one report of a randomized control trial of like 376 postmenopausal women who had received soy versus placebo showed a significant increase in endometrial hyperplasia over a 5-year period. So, considering all of those etiology, it's also important to note that 4 to 11% of postmenopausal women reported to have vaginal bleeding, and with those women, 5 to 10% of them is due to endometrial cancer. And in the United States alone, 92% of uterine cancer is endometrial in origin. So, um, the primary goal of diagnostic evaluation in postmenopausal women with uterine bleeding is to exclude malignancy, since age is a significant risk factor for this disorder. So through history and physical exam, as well as endometrial evaluation and cervical cytology, we should be able to assess the patient if they are at a higher risk of developing malignancy. First, with the history and physical exam, the menopausal status must be established. So questions regarding the patient's last menstrual period, or if she had any surgical history in cases of patients that have had menopausal, that are menopause secondary to an oophorectomy, should be elicited. So the nature of the patient's perimenses and current bleeding should also be assessed, since previous history of heavy menses or another abnormal uterine bleeding may increase suspicion for either structural abnormalities such as leiomyomas, or endometrial abnormalities like polyps, hyperplasia, or even malignancy itself. So heaviness of bleeding, number of days, associated symptoms like fever, pain, or changes in bladder or bowel function should also be elicited. as well as family history of cancer should be elicited from the history, particularly breast, gynecologic, urologic, or gastrointestinal cancers. So medications like anticoagulants may lead to vaginal bleeding as well. And as mentioned earlier, postmenopausal hormone therapy and certain herbal supplements stimulate the endometrial lining, which may lead to bleeding. So the patient's body mass index should be calculated since it's reported that obesity is a risk factor for endometrial cancer. And on physical examination, evaluation of the internal and external anatomy of the genital tract should be performed. So determining the bleeding site and if there are any suspicious lesions, lacerations, or foreign bodies should be identified. So the shape, size, and tenderness of the uterus can also aid in narrowing the differential diagnosis. And we should also note for findings of atrophy, which classically include pale, dry vaginal epithelium that is shiny and smooth and lacking rugae. So after history and physical exam, we can also do endometrial evaluation. So from what I read po in the book, endometrial biopsy is the suggested initial tool for evaluation if suspicious of malignancy due to its high sensitivity, low complication rate, and low cost. However, it's not sensitive for diagnosing structural abnormalities. And typically, a transvaginal ultrasound is used as an adjunct for diagnosis when an endometrial biopsy is done. But as of 2018, the American Committee of Gynecology recommends transvaginal ultrasound as the initial evaluation to be used for uterine pathology, since endometrial cancer can be reasonably excluded by ultrasound in postmenopausal women if the findings are a thin, less than or equal to 4 millimeter homogeneous endometrium. Mm, However, an endometrial biopsy following a transvaginal ultrasound is required if the findings are if the endometrial lining is greater than 4 millimeter, if the endometrium shows diffuse or focal increased echogenicity, if the endometrium is not adequately visualized on sonography, and if there is persistent bleeding. So next tool to use for diagnostic evaluation is cervical cytology. So routine cervical cytology should be done once sexually active, or at least when the patient is 21 years of age, then every 3 years until the patient is 30 years old, then every 5 years thereafter until the patient is 65 years old, or if a hysterectomy is performed. So routine cytologic examination can also be used for the diagnostic evaluation of cervical or endometrial cancer. It often detects endometrial carcinoma in approximately 50% of cases. So it's important to note that benign endometrial cells occasionally reported in women 45 years or older. But in cases of postmenopausal women, if we find benign endometrial cells, it is it these findings have a 3 to 5% risk of endometrial cancer. So to continue, endometrial carcinoma is a biologically and histologically diverse group of neoplasms characterized by a dualistic model of pathogenesis. So it's categorized as type 1 and type 2 endometrial carcinoma with each distinguishing features. So type 1 are endometrioid carcinomas that are estrogen dependent, low grade, and are derived from a typical endometrial hyperplasia, while type 2 are serous or clear cell histology with no precursor lesions and typically have a more aggressive clinical course. So Early diagnosis is entirely dependent on prompt recognition and evaluation of irregular vaginal bleeding. So, who are at risk of endometrial carcinoma? So, patients with chronically increased estrogen levels or estrogenic activity through systemic unopposed estrogen therapy from any route without concurrent administration of progestin results in a markedly increased risk of, developing endometrial carcinoma precursors and endometrial carcinoma itself. So, this can come from tamoxifen use in postmenopausal women, where tamoxifen acts as an estrogen agonist, which increases the risk of endometrial carcinoma, with an effect that is dose and duration dependent. Another risk factor is chronically anovulatory patients that continue to produce sex steroid hormones but without normal endometrial turnover. So there's chronic estrogen production unopposed by adequate progesterone production, which would allow continued proliferation of the endometrium, which can often lead to endometrial hyperplasia, which is a precursor for endometrial carcinoma. Another risk factor are patients that are obese, have high levels of endogenous estrogen due to the conversion of androstenedione to estrone and the aromatization of androgens to estradiols, which both occur in the peripheral adipose tissue. So another common risk factor is Lynch syndrome, which is a hereditary non-polyposis colorectal cancer. Patients with Lynch syndrome have up to 71% lifetime risk of developing endometrial carcinoma compared to the 2.7% of the general population. Similarly, if the patient has first degree relative that had endometrial carcinoma, um, the patient would have a 3.1% risk compared to the less than 2% of the general population. So, protective factors from endometrial carcinoma includes the use of estrogen progestin oral contraceptives, which decreases the risk of development of endometrial carcinoma by 30 to 40% in large epidemiologic studies, and the risk reduction persists even after discontinuation of this OCP use. So this is attributed to the progestin component, which suppresses the endometrial proliferation. So with that, progestin-only contraceptives would appear to provide greater protection against endometrial carcinoma. So other potential protective factors being studied is the increasing gravity and parity, older age at last birth, breastfeeding, as well as physical activity and proper diet. So diagnosis of endometrial carcinoma should, for premenopausal women, includes a history of prolonged heavy menstruation or intermenstrual spotting. While if it occurs in postmenopausal women, symptoms often include bleeding, abnormal vaginal discharge, pelvic pressure or pain, which often would mean that there is uterine enlargement or there is extrauterine tumor spread. So as mentioned earlier, endometrial biopsy, specifically office pipal biopsy or a transvaginal ultrasound, is used to diagnose malignancy, or in this case, endometrial carcinoma. But if there is cases that there is an abnormal bleeding, um, the patient may also undergo dilatation, and curettage would provide to be a diagnostic and therapeutic tool. So is there a role for tumor markers, specifically CA125 serum levels? So reports have that preoperatively, a high CA125 level may indicate a more advanced disease, while postoperatively, a CA125 level are used to monitor the patient's response to the therapy or during post-treatment surveillance. So endometrial carcinoma is classified histopathologically with endometrioid adenocarcinoma being the most common, with 75% of endometrial carcinoma cases. So it's often graded using this criteria, with grade 1 being 5% less than 5% of a non-squamous or non-morular solid growth pattern, which means that it is well differentiated and is indolent with little propensity to spread outside the uterus or recur, while grade 2 is 60 to 50% of a non-squamous or non-morular solid growth pattern with intermediate differentiation and prognosis, and grade 3, which would mean that there is greater than 50% of a non-squamous or non-morular solid growth pattern, which means that it is poorly differentiated, and there is an increased potential for a myometrial invasion and nodal metastasis. So basically, this histologic grading is this primarily determines the tumor's architectural growth pattern and its propensity to be gland forming. So endometrial carcinoma is surgically staged with staging, where here as described is with stage 1 being confined to the uterine corpus, 1A being limited to the endometrium involving less than half of the myometrium, while 1B is where there is invasion of half or more than 50% of the myometrium, while stage 2 is the invasion of cervical stroma but no extension outside the uterus. Stage 3 Stage 3A is the invasion of serosa, adnexa, or both with direct extension or metastasis. Stage 3B is the metastasis or direct spread to the vagina or spread to the parametria, with stage 3C further divided into stage 3C1, which there would be metastasis to the pelvic lymph nodes, and stage 3C2, where there is metastasis to the para-aortic lymph nodes with or without metastasis to pelvic lymph nodes. And stage 4A with the invasion of the bladder, intestinal mucosa, or both, and stage 4B with distant metastasis, including metastasis to the inguinal lymph nodes, lungs, livers, or bone, and intraperitoneal diseases. So the next is the pattern of spread. There are 4 major channels of lymphatic drainage from the uterus that serves as sites for extrauterine spread of tumor. One is a small lymphatic branch along the round ligament that runs to the inguinal femoral nodes. Another is the branches of the tubal and ovarian pedicles, which are large lymphatics that drain into the para-aortic nodes. And lastly, the broad ligament lymphatics that drain directly to the pelvic nodes. So of these, the most important clinically is the pelvic and para-aortic node drainage sites, where lymphatic channel invasion and metastasis to the pelvic and para-aortic nodal chains can follow tumor penetration of the myometrium. So, treatment of endometrial carcinoma is surgery with hysterectomy and salpingo-oophorectomy being the mainstay of management, with the goal of removing the primary tumor and to identify the prognostic factors to determine whether adjuvant therapy is required. So, following surgery, surveillance should be done with pelvic examination every 3 to 6 months for the first 2 years, and then every 6 to 12 months thereafter. So intermittent imaging may also be done if indicated, as well as mentioned before, CA1 to 5 levels if it was elevated prior to treatment. So Medical management of patients with endometrial carcinoma includes chemotherapy, namely the TAP regimen, where only three cytotoxic drugs with definite activity for endometrial cancer have been identified. So this is paclitaxel, doxorubicin, and cisplatin, which is the adjuvant treatment option for advanced endometrial cancer following surgery. So radiation therapy. Um, Primary radiation therapy is rarely done and is mainly for poor surgical candidates. And typically, they use the intrahavitary brachytherapy as the method. While adjuvant radiation therapy is for those at risk of cancer recurrence, but for those with low risk early stage cancer, typically surgery is already an adequate treatment. Another is hormonal therapy for non-surgical candidates. May use continuous progestin treatment or a levonorgestrel releasing IUD, while as an adjuvant, a single agent high dose progestin is preferred if with advanced or recurrent diseases. Mm, Prognosis of endometrial carcinoma is determined primarily by the disease stage and histology, including both the grade and histologic subtypes. So, fortunately for endometrial carcinoma, most women have a favorable diagnosis since it presents early and is identified early. So, as of 2010, the survival rate is as follows, with stage 1A being the highest at 90.3%. That's all po. Here are my references.
So what's your take
Thank
home
you.
point as far as postmenopausal bleeding would be concerned?
I think po it's important that patients that have postmenopausal bleeding should be screened properly since, as mentioned earlier, the primary goal is to exclude malignancy since at that point, postmenopausal bleeding is would be people that experience postmenopausal bleeding would be at risk of developing malignancy po.
Okay. Um, Postmenopausal bleeding, unless proven otherwise, and how do you prove otherwise that it's not malignancy, and that is to do a endometrial biopsy. Your endometrial biopsy is an office procedure, but usually in women more than 50, the menopausal women, they would have a lot of comorbidities such that it's usually done um, in the operating room. Like it or not, this patient is also affected by your COVID. Don't you agree that there is delay in treatment for this patient?
Yes po, Doc. Because initially, when she was supposed to have the dilatation and curettage, she was not able to have the procedure just because she wasn't able to obtain a CT clearance po for procedure.
Okay. So, one is delay. Had we seen her earlier? What was the biopsy? What was the biopsy? What was the result?
Uh,
Endometrial adenocarcinoma agad.
yes po, Doc.
So, it was already. So, when you do a biopsy, okay, I know it's not your, it's part of your topic, postmenopausal bleeding. What are your expected findings? When you do a biopsy, what are your what's the spectrum before we go to clear cut no? Carcinoma agad. But before we reach carcinoma, what are your findings as far as endometrial biopsy is concerned? Pag benign,
Um, uh, yung endometrial lining po,
hmm.
Doc.
What would be found in your endometrial lining? Carcinoma ang binasa ni Winona. Hindi mo alala? You can't remember? Before you reach your endometrial carcinoma, your findings would be your simple, simple hyperplasia with or without atypia, complex hyperplasia with or without atypia. So of course, your complex hyperplasia with atypia would have the higher predilection to your malignancy, and you would like your simple hyperplasia without atypia, only 1% would progress into malignancy. So those are your expected findings as far as your endometrial biopsy is concerned. So your disordered proliferative endometrium, that is your simple hyperplasia. Okay? Ano pang mga paboritong yung nababasa? Basal endometrium, pag younger, endometrium, secretory endometrium. Yan. Ibig sabihin, nagpa-ultrasound ka, hindi day 5 to day 8. So, hindi makita si endometrium kasi puro dugo, hindi pa siya na-flash. That's why it's also important, I know it's not part of your report, for your menstruating, your reproductive aged women to assess it day 5 to 8 of menses so that you could assess the endometrium better. Okay? Thickness of your endometrium post-menopausal, anything that is more than 0.4 warrants a biopsy. That is your thickened endometrium for post-menopausal women. Okay. All right, good. That's only my take-home point. If you're not all going to be OBGYNs. Okay? We accept that. But when you do GP, when you do internal medicine, any menopausal women presenting with bleeding, even in a minuscule amount, warrants investigation. Okay? Next.
Thank you po.
Ilan pa?
Next,
Dalawa
Doc.
pa?
Yes, Doc.
Sige.
PGI trompeta, Doc.
Mag-exam kayo na 11 o'clock. Joke lang.
Share na po ako, Doc.
Sige, share mo na.
Good afternoon, everyone. Good afternoon, Dr. Andres. I'm Pauline Trompeta, presenting to you the case of DA. DA is a 50-year-old previous farmer, married for 37 years to a 59-year-old previous farmer, and was admitted last April 23. They admitted the patient with the chief complaint of vomiting. Patient underwent tubal ligation last 1991, has hypertension since 2011, with maintenance dose of 50 mg losartan taken once daily and 10 mg amlodipine once a day. No history of HPV virus vaccination. Mother has hypertension but no known chronic illnesses. Menarche was at 11 years old, has irregular period, longest is 3 months interval, lasting for 3 days using 3 moderately soaked pads with no dysmenorrhea. Oral contraceptive use last 1989 to 1991, but name of pills was unrecalled. Pap smear done last 2021 under Dr. Noble at LDPH. Result was benign as per the patient. Patient had her menopause last 2017. Patient is Gravida 6, Para 4, 4024. Gravida 1 last 1983 with incomplete abortion, underwent dilatation and curettage at Parañaque Hospital. G2, G3, G2 last 1984, G3 last 1983 to a full-term girl delivered at home. G4, G5, G4 last 1987, G5 last 1989 to a full-term boy delivered at home also. G6 last 1991 had incomplete abortion and underwent dilatation and curettage at Perpetual Las Piñas. Patient is previous smoker, 9 pack years, and occasional alcoholic beverage drinker. BP of patient during physical exam, patient BP was 120/70, heart rate of 79, respiratory of 20, afebrile with a temperature of 35.6. With no pallor, pink palpebral conjunctiva, moist lips and oral mucosa, with clear breath sounds, abdomen was soft, with hypogastric tenderness, no mass palpated. During the speculum exam, cervix is converted to a bulky necrotic mass with irregular borders and irregular contour, foul smelling with no bleeding or discharge. On IE, cervix is converted to approximately 10 by 7 centimeter mass, firm with irregular borders and irregular contour, extending the upper 2/3 of the vagina. Uterus and adnexa cannot totally be assessed due to pain with blood per examining finger. Patient has good sphincteric tone and fixed parametrial bilateral. 7 months prior to admission, patient noted vaginal bleeding using 3 to 4 moderately soaked pads per day. With no clots, no associated symptoms, with persistent bleeding, but no consult done and no medications taken. 5 months prior to admission, noted with persistent bleeding, but at this time, volume increase from using 4 regular pads to 6 fully soaked diapers with blood clots, but no associated hypogastric pain, dizziness, or weakness. Still, no consult was done. 4 months prior to admission, increased amount of bleeding was noted. From 6 fully soaked menstrual diaper to 8 fully soaked menstrual diaper with blood clots, now associated with weakness and dizziness. Patient sought consult at Zarate Hospital but unrecalled the name of the OBGYN. The patient was advised for ultrasound and was done. Transvaginal ultrasound revealed the measurement of the uterus endometrium. The endometrial cavity is dilated up to the endocervical with a non-uniform echogenicity, midline echo not defined. The color flow on color mapping shows that endometrial myometrial junction is irregular, suggestive of endometrial pathology. Transvaginal ultrasound also revealed the measurement of the right and left ovary and cervix. Bulky as measured with hypoechoic structure at anterior wall measuring 2.98 by 3.28 by 1.63 centimeters. The color flow on color flow mapping cannot rule out cervical pathology. Patient was for endometrial biopsy and was prescribed with tranexamic acid 500 mg 3 times a day for 7 days. Patient noted that the amount of bleeding decreased for a few days but unrecalled the exact number of days. At this time, patient only using 1 diaper moderately soaked pad per day. The patient sought second opinion and was advised to continue tranexamic acid for 7 more days and prescribed with dexketopropofen 25 mg as needed for hypogastric pain with a pain scale of 5/10. 3 months prior to admission, still with vaginal bleeding associated with weakness and pallor, patient consumed the tranexamic acid, noted 1 moderately soaked pad per day. In pursuit for second opinion, she consulted Dr. Noble at LDPH and finding out that the CBC done, there was a decrease in hemoglobin. However, exact volume was unrecalled. The patient was advised for admission for correction of anemia. So 5 units of packed red blood cell was transfused, and at this time, endometrial biopsy was done under Dr. De Castro. Endometrial biopsy showed that there's very small focus of a typical large cell in an hemorrhagic necrotic background. The service under Dr. Noble was already transferred at the moment to Dr. De Castro as the OBGYN. So the basis of the diagnosis is that upon examination, it was noted that there are 6 parametria. It is it is considered the involvement of the sides of the pelvic wall. And according to the requested transvaginal ultrasound, where it shows that cervix is bulky as measured with hypoechoic structure at anterior wall measuring 2.98 by 3.28 by 1.63 cm, and a color flow showing that cervical pathology cannot be ruled out. Whole abdominal sonography was also done and revealed that both kidneys are normal functioning and is noted not to have hydronephrosis. 2 months prior to admission, still with vaginal bleeding, patient used 1 minimally soaked pad per day. There is this plan to do the radiotherapy and chemotherapy, but due to lack of fund, patient was referred to PGH, where cervical punch biopsy was done. It revealed that round spindle cell neoplasm favoring carcinosarcoma. Due to conflict of schedule for radiotherapy, patient returned to the attending physician as private patient, and then the patient was facilitated at Junelta and was given the blood transfusion. 1 month prior to admission, there's still persistence of bleeding. Patient used 1 minimally soaked menstrual diaper. It is associated with weakness. The patient was admitted direct room in for 2 days because of hemoglobin of 56, and then 4 units of packed red blood cell was transfused, and after 2 days, patient was cleared for chemo and radiotherapy. Morning prior to admission for radiotherapy, the hemoglobin level went to 80, and then patient was transfused with 2 units packed red blood cell while ongoing radiotherapy. The plan here was to send the patient home, but 6 hours prior to admission, 1 episode of vomiting of previously ingested food and water occurred, and the volume was approximately half a cup. And then this was associated with nausea, weakness, and easy fatigability. So the patient went to ER, and at ER, 1 episode of vomit happened, and then with accompanied with hypogastric pain with the pain scale of 6 to 7 over 10. The admitting diagnosis is G6P4 4024 carcinosarcoma cervix stage 3B. Radiation-induced emesis, multiple electrolyte imbalance, moderate anemia, secondary to malignancy, status post radiotherapy for April 23, status post endometrial biopsy for very small foci of atypical large cells in a hemorrhagic necrotic background, status post cervical punch biopsy for carcinoma at PGH last Feb 23, 2020, and bilateral tubal ligation last 1991 at PHMC and hypertension stage 2. So the initial plan with this patient was to give ondansetron 8 mg IV, paracetamol 300 mg IV. Because vital sign was stable with BP of 110/70, heart rate of 79 and respiratory of 20 and temperature of 35.6. However, patient needs to be admitted and observed because at around 12 a.m. upon admission, electrolytes revealed that it is imbalanced. So sodium level is 133, magnesium level is 0.77, chloride level is 97. Patient is due for radio-oncology for 28 days and 5 more cycles of cisplatin. So in day 1, the vital signs was stable. The diet was nothing per RM, and then upon admission at the ER, the cervix is converted to bulk necrotic mass with irregular borders and irregular contour with foul smelling and no bleeding or discharge. And during the IE, cervix is converted, and then 10 by 7 centimeters mass was palpated. It was firm with irregular borders and irregular contour, extending at the upper two-thirds of the vagina. The uterus and adnexa cannot totally be assessed due to pain with blood in examining fingers. Patient had good sphincteric tone. So patient used one minimally soaked menstrual diaper, treated with ondansetron 8 mg IV once a day, and paracetamol 300 mg IV every 4 hours as needed. Patient is at CLGL at 12 noon, and at 4 p.m., patient had soft diet, and at the afternoon of day 1, vital signs was 120/80, heart rate of 80, respiratory rate of 21, temperature of 36.2. Patient was awake, no pallor, pink palpebral conjunctiva. Patient was slightly pale. There was a perineal pain in labia with bleeding, pain scale of 8/10. This is the time when 1 unit packed red blood cell was started, noted with bloatedness. So the abdominal pain scale was 10/10. Patient was irritable, and then paracetamol 300 mg IV was administered. And then the pain decreased around pain scale of 5/10. The patient consumed a total of 7 adult diaper, 4 fully soaked, 3 moderately soaked, with a pain scale of 6/10. And then tranexamic acid was given, and a request for a repeat CBC was done. Patient was referred back to radio if it is possible to increase the high dose in radiotherapy. There were no recurrence of vomiting. Day 2, vital signs was 130/70, heart rate of 86, respiratory rate of 20, temperature of 36.6. Patient is awake, no pallor, slight pale palpebral conjunctiva, not in pain. Patient was comfortable. She was able to eat while sitting down, and then she can tolerate already the pain. Consumed 1 minimally soaked diaper. The CBC, the repeated CBC revealed that the hemoglobin was 82. And then patient was still referred to the rad-onco. In day 3, patient was awake, comfortable, no pallor, pink palpebral conjunctiva. She can tolerate the pain with a pain scale of 5/10. Was able to sleep well after taking paracetamol. Patient is in diet as tolerated. IV fluids to 16 hours was increased. Status post 1 unit P, packed red blood cell for 1 unit P or packed red blood cell. And then for radiotherapy, it was not done. So she was given bisacodyl suppositories, 2 doses, and paracetamol 300 mg IV from Q4 to Q6. There was no vaginal bleeding, no recurrence of vomiting. In rad-onco, only 1 unit of packed red blood cells was only given because the RT-PCR was given was negative, but was taken last April 17. So the relative consent to the as consent to conduct it as outpatient. So at this time, patient was has will the attending physician needs to approve if patient may go home, and on the 4th day the patient was discharged. As of last May 28, patient had radiotherapy in a total of 9 days and 3 cycles of chemotherapy. However, the initial brachy was canceled last 20 due to insufficient funds, and then that was the time the CP clearance was already given. However, and numerous follow-up was done, but the patient lost follow-up. So for the discussion is divided in 2 parts: diagnosis of the patient, that is focused on cervical carcinosarcoma, and in the second part, the cervical carcinoma. According to extracted journal by Kim Lee, cervical carcinosarcoma is a rare case most commonly occur in postmenopausal women. Cervical carcinosarcoma is derived from two different origins, the Mullerian duct and the mesonephric duct. Origin of cervical carcinosarcoma is yet to establish. However, according to Meguro, that at 16% of the origin of cervical carcinosarcoma originate from mesonephric duct. Cervical carcinosarcoma is a metaplastic change of carcinomas composed of carcinomatous and sarcomatous elements arising from a single malignant cell. Most common in postmenopausal women with a mean age of 64 and diagnosed at a range from 25 to 93 of years. It is manifested with vaginal bleeding and mass on the cervix. The immunohistochemical studies, such as the markers CD10, calretinine, estrogen receptor, and the use of cervical punch biopsy to assess the possible origin or the diagnostics for this case. For the treatment, we have total abdominal hysterectomy, salpingo-oophorectomy, pelvic node dissection, and combined radiation alone or both radiation and chemotherapy. Cervical carcinoma is the third most common malignancy of the lower female genital tract after endometrial and ovarian cancer, and second most common of death after ovarian carcinoma. This carcinoma can be easily present at an early age. Similar to other forms of cancer, that it has been diagnosed early, prognosis will be better. The character of the metastasis is that initially a locally infiltrating cancer that spreads from the cervix to the vagina and then paracervical and to the tissues located cranially, the ureter, between the uterine corpus and pelvic sidewall surrounding the sidewall areas. Grossly, it may be ulcerated and have a cauliflower-like appearance extruding from the cervix. Is that either exophytic or endophytic. Usually start from the endocervical location and often fill the cervix and lower uterine segment, resulting to look like a barrel-shaped cervix. So it is assessed with the aid of biopsy, so that to clarify whether the tumor has spread outside the abdomen. To determine the prognosis of the cervical carcinoma, we make use of the FIGO staging, which determines the depth and extension of invasion in affected organs. So stage 1, the carcinoma is strictly confined at the cervix, so it extends to the corpus, but this is disregarded. If the carcinoma extends to the corpus, it is disregarded. So 1A, invasive carcinoma, diagnosed only by microscopy. Deepest invasion is less than or equal to 5 millimeters, and then largest extension is greater or equal to 7 millimeters. Stage 1A1, no deeper than 3 millimeters and no wider than 7 millimeters. It is also called the microinvasion carcinoma. Stage 1A2, maximum depth deeper than 3 millimeters and no deeper than 5 millimeters taken from the base of the epithelium, and horizontal invasion at more than 7 millimeters. So for stage 1B, the lesion is visible, limited to the cervix, uteri, or the preclinical cancer greater than 1A. For 1B, the lesion is 4 centimeters in greatest dimension, while for 1B2, the lesion is 4 centimeters in greatest dimension, is greater than the 4 centimeters. So in stage 2, there's the cervical cancer that invades the uterus but not to the pelvic wall or lower third of vagina. So clinically, the carcinoma involves the vagina but not the lower third of the vagina. On the for the stage 3, tumor extends the pelvic wall or involves the lower third of the vagina or causes hydronephrosis or non-functioning kidneys. As for our case, it shows on transvaginal ultrasound that it is categorized as case 3B due to the extension to the pelvic wall, lesion extension to the pelvic wall. So stage 4, carcinoma has extended beyond the true pelvis or has involved the mucosa of the bladder or the rectum bolus edema. As such, does not permit a case to be allotted to stage 4. So how do we screen cervical carcinoma? So it is at age 21 that we started to screen for cervical carcinoma, or within 3 years of onset of sexual activity, and thereafter every 3 years. Every 5 years if after 30 women who have had normal cytology results are negative for HPV. A cervical cytology is repeated every 6 to 12 months if women with a normal cytology result but the test is positive for high-risk HPV DNA. When a pap smear is abnormal, a colposcopic examination of the cervix and vagina is performed to identify the lesion. So for the treatment, radiation alone or radiation and chemotherapy. So chemoregation is the treatment used for the stage 3B to stage 4A, followed by 1 or 2 brachytherapy implants with cisplatin 4 milligram per per milligram per m squared to optimize result. So the complications of the radiotherapy usually develop in 1 to 2 years, but can occur as early as 6 months or late as many years after radiation therapy has been completed. So if this a complication could be the scarring of normal tissues, which can lead to severe radiation fibrosis. So after ruling out infection, symptomatic treatment is undertaken with antispasmodic drugs such as hyoscine and butylbromide, as what our patient in the case, she received the medication at 3rd day of confinement. That's all. Thank you.
Okay. So cervical carcinoma again. Delay in treatment? Who knows? Have we diagnosed this earlier? It may have been a simpler case, but I think your cervical carcinosarcoma by itself makes it a more aggressive
Yes.
entity to deal with. Okay, so how will you prevent cervical cancer as far as epidemiology will go? It's one of the cancers that in developed countries they have already more or less decreased prevalence primarily because of screening and vaccination.
Yes.
However, in um, third world countries such as the Philippines, uh, pap smear or survey or screening rates are quite low. Vaccination rates are quite low, such that there's a non-available vaccine, but it's pulled out by the company and distributed to other countries that utilize it more. What does it tell us? What does that tell us? Vaccine utilization here is very low.
Yes.
Even if it's the cheaper Gardasil, which would cost still around 4,000 to 5,000 per shot at the very least, vaccine utilization is low. Hence, the occurrence of your cervical cancer prevalence it's still very significant. Again, it's presents with bleeding, etc., etc. And if detected early, prognosis is very good. That's why we have to really screen our patients and advise our women to go for screening, at least for the pap smear. If the patient could afford, there's HPV DNA, which has higher sensitivity and specificity. Okay. Is this the next na? Could the last share the screen? Okay. Good, intern Pauline. Let's have our last report.
Ano ba yun? Ay, wait lang po. Kita na po ba? Ay, paano ba?
Yes, Doc.
Okay, good afternoon, doctors. I'm PGI Janeline II of Visaya. I'm here to present a case about incomplete abortion. So, Patient JF, 24 years old, female, single, call center agent, Filipino, Catholic, and admitted at our institution for the first time last March 31, 2021. Um, Came in with a chief complaint of vaginal bleeding with a past medical history of allergic to mefenamic acid. Family history is unremarkable. For the personal and social history, the patient is working as a call center agent, cohabiting for 6 years with 28 years old male store clerk, non-smoker, non-alcoholic drinker, and denies illicit drug use. Menarche at the age of 11 with regular intervals, lasting for 3 to 5 days, using 3 pads per day, moderately soaked, no dysmenorrhea, no history of IUD, exposure to STD, and no pap smear was done. She had her first sexual contact at 16 years old with 3 concurrent partner, no history of dyspareunia and coital bleeding, with history of undercold oral contraception used for 2 months last year, 2020, from the health center. So our patient is G3P2 2002 G1 in 2016, delivered in full term baby boy by spontaneous vaginal delivery in lying in Cavite with birth weight of 3.4 kilograms with cleft lip. G2 in 2019, delivered in full term baby girl by spontaneous vaginal delivery in lying in Cavite with birth weight of 3 kilograms and with no complications. For the LMP of the patient, last January 30, 2021, age of gestation is 8 weeks and 4 days, and the expected date of delivery is November 6, 2021. And no prenatal check was done. So history started. Patient missed her menses for 6 weeks. Pregnancy test done, revealing positive result. No consultation done. No medications taken until 1 day prior to admission. The patient noted vaginal spotting, no hypogastric pain or other signs and symptoms. Consult was done at other institution. And at the ER, the patient was given dihydrogesterone 10 milligrams, 4 tubs loading dose, and sent home with dihydrogesterone 10 milligrams once a day. And also, the patient was advised ultrasound, but was not done. Until few hours prior to admission, the patient noted heavy vaginal bleeding using 3 diapers, fully soaked with blood clots. At this time, still no hypogastric pain or other signs and symptoms. And due to bleeding, the patient sought consult at our emergency room. So initially at the ER, the BP of the patient is 110/70, pulse rate is 98, RR is 20, febrile, um, with pale palpebral conjunctiva and noted palmar pallor, and the abdomen is soft, non-tender. Upon speculum exam, cervix was pink, smooth, with noted blood clots amounting to approximately 300 cc, with placental issue plugging the os. On internal examination, cervix was soft, open, uterus enlarged, about 8 to 10 weeks, no cervical motion tenderness, no adnexal mass or adnexal tenderness. On rectovaginal exam, no intraluminal vaginal mass palpated in parametry. Again, at the ER, the patient is initially stable. So upon evacuation of the blood clots amounting approximately 300 cc, the patient was noted to be hypotensive with 70/50 and tachycardic at 100, 108 beats per minute, and diaphoresis was noted. So at the ER, double line was started. Initially, a fast drip of 500 cc of plain NSS, and on repeat BP of 90/70, and the heart rate was 90s. And another fast drip was given of plain 500 cc of plain NSS, and a total of 1 liter was given to the patient. And the second line is D5LR with 10 units of oxytocin. So subsequently, the patient was admitted, but due to No swab test done. The patient was admitted to the room 515. So the admitting diagnosis is G3P22002, incomplete abortion, 8 weeks and 4 days, age of gestation, non-septic, non-induced hypovolemic shock, secondary to acute blood loss, mild anemia. So for the plan for this patient is for completion curettage and correction of blood loss. So for pre-op, the patient was stable with 120 over 80. Upon speculum exam, noted 200 cc of blood clots, and upon IE, cervix is soft, closed, uterus enlarged about 8 to 10, no cervical motion tenderness, no adnexal mass, no adnexal tenderness. So intra-op, in intra-op, still noted clotted blood at the vaginal canal, and obtain half cup of specimen of product of conception, non-necrotic, non-foul smelling, and the patient is stable before the induction of anesthesia. But upon induction, the patient becomes hypotensive, 80 over 40. Day zero post-op, the patient has no episodes of, upon repeat BP, the patient has no episode of hypotension. So CBC, post-op revealing hemoglobin of 74. So the patient was for blood transfusion of two pack RBC. On post-op day one, the patient was stable and two blood transfusion was done at around 2 p.m. and so CBC was requested, status post 6 hours blood transfusion. And now the CBC hemoglobin revealed 104. And also the patient was negative in swab. So the patient on that day is for discharge. The patient has been discharged. So for the final diagnosis, G3P22012, incomplete abortion, 8 weeks and 4 days, age of gestation, non-septic, non-induced, status post-completion, curettage, hypovolemic shock, secondary to acute blood loss, resolved, severe anemia, secondary to acute blood loss, corrected, status post transfusion. So abortion. Abortion, defined as spontaneous or induced termination of pregnancy before fetal viability, comes from the Latin word aborire, to miscarry, meaning to miscarry. Miscarriage and abortion are terms used interchangeably in a medical context. So, abortion is a pregnancy termination before 20 weeks gestation or with the fetus born weighing less than 500 grams. So, types of abortion are the following: spontaneous includes threatened, inevitable, incomplete, complete, and missed. Under spontaneous, there is septic abortion. It is used to further classify any of these that are complicated further by infection. Recurrent abortion is variably defined, but it is meant to identify women with repetitive miscarriage. And lastly, induced abortion is surgical or medical termination of a live fetus that has not reached the viability. So, more than 80% of spontaneous abortion occurs within the first 12 weeks of gestation. So the first trimester losses, demise embryo or fetus nearly precedes spontaneous expulsion. So for the pathogenesis, that is usually accompanied by hemorrhage in decidua basalis, followed by adjacent necrosis that stimulates uterine contractions and expulsion. So for the etiology, fetal factors, approximately half of the miscarriages are anembryonic, that is with no identifiable embryonic elements, isolated ovum. And other half is embryonic miscarriages.
Sa maingay.
So half of these embryonic um, miscarriages is aneuploidy and euploid. For this aneuploidy, both um, both abortion and chromosomal anomaly rates decline with advancing gestational age. 75% of chromosomal abnormal abortions occurs by 8 weeks gestation. So, of chromosomal abnormalities, 95% are caused by maternal gametogenesis and 5% present by paternal errors. So, autosomal, autosomal, autosomal trisomy is the most frequently identified chromosomal anomaly. Monosomy X or 45X is the most frequent specific chromosomal abnormality called Turner syndrome. Triploidy is often associated with hydropic or molar placental degeneration. So for maternal factors, of course, first, the age. Second is infections. Third, disorders like diabetes mellitus, thyroid, and other medical disorders. Medications or poor nutrition, surgical procedures performed during early pregnancy do not increase the risk of abortion, except if it involves early removal of the corpus luteum or the ovary in which it resides. Also, cancer survivors who were previously treated with abdominopelvic radiotherapy and chemotherapy. Also, the occupational and environmental factors, such as for the environmental, such as the arsenic, lead, formaldehyde, benzene, and etc. For the immunologic factors, like the APAS and uterine defects. For paternal factor, chromosomal abnormalities in spermatozoa likely play a role. So this is the classification of spontaneous abortion: threatened, inevitable, incomplete, complete, missed, and septic. For threatened abortion, this is diagnosis is presumed when vaginal bleeding or vaginal discharge appears through a closed cervical os during the first 20 weeks. This bleeding in early pregnancy must be differentiated from the implantation, which some women have at the time of their expected menses. So, aside from this, almost one-fourth of the women develop bleeding during early gestation that may persist for days or weeks. So, it may accompanied by suprapubic discomfort, mild cramps, pelvic pressure, or persistent low backache. So, bleeding is by far the most predictive risk for pregnancy loss. So, one of the differential diagnoses for this patient is ectopic pregnancy. Because ectopic pregnancy in early pregnancy presented with also with vaginal bleeding. So both may present with missed menses, pain, and vaginal bleeding. So the primary goal is prompt diagnosis of ectopic pregnancy. A serial quantitative serum beta HCG levels and transvaginal sonography are integral tools. So, serum beta HCG should rise at least 53 to 63% every 48 hours. Although these are less used markers, serum progesterone levels uh, less than 5 nanograms per milliliter suggests a dying or ectopic pregnancy, while more than 20 nanograms per milliliters um, means healthy pregnancy or possible viable pregnancy. And transvaginal sonography is used to locate the pregnancy and determine the viability. So for the management for threatened abortion, observation is a norm. Acetaminophen-based analgesia will help relieve discomfort from cramping And bed rest is often recommended, but does not improve the outcomes. When you say inevitable abortion, there is bleeding, pain, with or without fever. And there is a presence of gross rupture of membrane plus cervical dilatation. So the management is uterine evacuation. So for incomplete abortion, so during abortion, bleeding follows a partial or complete placental separation and dilation of cervical os. So before 10 weeks gestation, the fetus and the placental parts are expelled together. And if more than 10 weeks age gestation, they deliver separately. So thus, the tissue may remain entirely within the uterus or partially extrude through the cervix. So products lying loosely within the cervical canal can be easily extracted with the ring forceps. So in our uh, patient, um, it has bleeding, blood clots, which is a passage of placental meaty tissue, and the cervix is open. And the patient is hypogastric, so contractions may be present or not. For the management, um, there are three options. It includes curettage, medical, or expectant. But these two are differed in clinical unstable or those with uterine infection. So are in case, remember, the plan is completion curettage because the patient is unstable and due to heavy bleeding, blood transfusion was needed. Mhm. So for complete abortion, there is complete heavy bleeding and pain with the passage of placental meaty tissue and the cervix is closed. Remember that, okay? And again, the patient are encouraged to bring in past tissue in which a complete gestation should be discerned from blood clots or residual cast. If an expelled completion sac is not identified, transvaginal sonography is performed to differentiate a complete abortion from threatened abortion or ectopic pregnancy. So, the characteristic findings of complete abortion is minimally thickened endometrium without a gestational sac. So, also the serum beta HCG levels drop quickly. So, for missed abortion, um, this is dead products of conception retained for days to months in utero with a closed cervical os. The premise is there is a early part of pregnancy appeared to be normal, but after the embryonic death, spontaneous miscarriage will eventually ensue. For septic abortion, it is an abortion complicated by infection. Organism may invade myometrial tissues and extend to cause parametritis, peritonitis, septicemia. These women may be afebrile with foul smelling discharge or bleeding. And the cervix is open with uterine and or adnexal tenderness. So for the management of septic abortion, um, there is curettage if there are retained products of conception. We can also use we can also give broad spectrum antibiotics and also put the patient in intensive care if the patient experiencing septic shock. Also, we can give doxycycline as a prophylaxis 100 milligrams 1 hour prior to evacuation and 200 milligrams post evacuation. And for medical abortion, we can give 100 milligrams once a day for 7 days together with patient administration. So for recurrent pregnancy loss or RPL, it is classified, defined as classically defined as three or more consecutive pregnancy losses less than 20 weeks gestation or with a fetal weight less than 500 grams. There are etiologies like acceptedly etiologies of RPL like parental chromosomal abnormalities, APAS, uterine abnormalities, and endocrine abnormalities. So for mid trimester abortion, it is a fetal loss that extends from the end of the first trimester until the fetus weighs equal or more than 500 grams or gestational age reaches 20 weeks. For etiology, unlike the earlier miscarriages, the frequently are caused by chromosomal aneuploidies. These later fetal losses are due to multitude of causes like second trimester abortion are medically induced because of fetal abnormalities detected by prenatal screening programs for chromosomal aneuploidy and structural defects. So etiology are the following: fetal anomalies, uterine defects, placental causes, and maternal disorders. For the classification, it is similar to the first trimester miscarriages. The management is also similar to the first trimester abortion, except the use of oxytocin for labor augmentation and surgical evacuation is technically more difficult. So, cervical insufficiency or incompetent cervix is characterized classically by painless cervical dilation in second trimester. It can be followed by um, prolapse and ballooning of membranes into the vagina and ultimately expulsion of immature fetus. Risk factors are the following: previous cervical trauma, such as dilatation and curettage, curization or amputation, or abnormal cervical defect. We can diagnose it through transvaginal sonography. The cervical length is less than 2.5 centimeters. And also there is fanning, means there is ballooning of membranes into the dilated internal os. So the management of incompetent cervix is cerclage. So for the cerclage, the contraindications usually includes bleeding, uterine contraction, ruptured membrane. So for prophylactic cerclage, before dilatation, it means the cervix is closed, is preferable. But a rescue or emergency cerclage can be performed after the cervix is found to be open or dilated. So the timing of the surgery is usually done between 12 to 14 weeks of gestation. So McDonald's cerclage is a running suture placed in the body of the cervix near the internal os to encircle the cervix. It's tightened to reduce the cervical canal to 5 to 10 millimeters, like this. For modified Schrodker procedure, it is more complicated and involving an anterior incision, placement, and tying of special Mercilin tape with suturing of the tapes of the cervical mucosa back in place. It is reserved for patients that have had failure with McDonald's procedure. So there is transabdominal cerclage. This suture is placed at the uterine isthmus and can be used if there are severe cervical anatomical defects or if there have been prior transvaginal cerclage failure. So complications include membrane rupture, preterm labor, hemorrhage, infections, or combination of. So for induced abortion is defined as medical or surgical termination of pregnancy before the time of fetal viability. So the definition used to evaluate this statistically include abortion ratio means the number of abortions per 100 per 1,000 live births, and abortion rate is the number of abortion per 1,000 women aged 15 to 44 years old. So, therapeutic abortion refers to the termination of pregnancy for medical indications like persistent cardiac decompression, fetal pulmonary advanced hypertensive vascular disease, malignancy, rape or incest. And most abortion done today are elective, by request, no medical reason. So for the methods of first trimester abortion, um, surgical abortion, for surgical abortion, surgical evacuation is performed transvaginally through an appropriate dilated cervix. So cervical preparation or cervical ripening is used to soften or slowly dilate the cervix. Also to minimize the trauma from mechanical dilation. So we can use hygroscopic dilator or osmotic dilators. These devices that draw water from cervical tissues and expand to gradually dilate the cervix. So this is laminaria. Laminaria is used to dilate the cervix. It is made of seaweed. We insert it to the cervical canal in order to absorb the water from the cervix and partially dilate the cervix so we can access the cervical canal and easily insert the curettage instrument. And the Dilapan S is composed of an acrylic base gel. Each type expands to an ultimate diameter 3 to 4 times that of its dry state. However, Dilapan S achieved this in 4 to 6 hours, which is faster than the 12 to 24 hours needed for laminaria. So for vacuum aspiration, also called suction dilation and curettage or suction curettage, this is transcervical approach to surgical abortion. So dilatation and curettage is the most common to dilate the cervix and evacuate by manual or mechanically scraping out the product of conception. So for the complications, perforation are more common with a retroverted uterus and usually recognized when the instrument passes without resistance deep into the pelvis. Also, laceration are not uncommon but potentially serious. Also includes the incomplete removal of products, hemorrhage, bowel injury like severe peritonitis, sepsis, and sudden severe consumptive coagulopathy. So for the first trimester medical abortion, can be used in outpatient medical abortion, um, a menstrual age of less than 63 days. And it is legally induced abortion performed at less than or equal 8 weeks of gestation. One third are completely medically in the United States. So the following are mifepristone, misoprostol, and methotrexate. So for the second trimester abortion, the following are indications like fetal anomaly or death, maternal health complications, inevitable abortions, desired termination, dilatation and evacuation can be used. Um, more than greater than 13 weeks, mechanical destruction and evacuation of fetal parts. And dilatation and extraction uses suction cannula to evacuate the intracranial contents after delivery of the fetal body. Also, medical abortion for trimester can also can be used mifepristone, misoprostol, and the prostaglandin has been added, the dinoprostone. So the consequences of elective abortion are the following: increase in post-abortive infection, other abortion, or preterm delivery. For the post-abortal contraception, ovulation resume as early as 8 days, but the average time is usually in 3 weeks. If another pregnancy is desired, effective contraception method initiated soon after abortion. So an IUD inserted after the procedure, and any of the various forms of hormonal contraception can be initiated at this time. And for women who desire another pregnancy, sooner maybe repairably to later. That's all po.
Pretty common, as I've said to my patients, again, delay of diagnosis, delay of prenatal checkup, poor prenatal, antenatal care will bring about a lot of complications. And in the first trimester, it is abortion. So, it's not, sorry. Let me answer this first.
Paano mag-end? Ay, ganito. Paano mag-end na? Ito pala. Ito, sorry.
Sorry. Okay. So, one. And another point, what did they do with this patient?
Completion curettage po.
Curettage. Okay. Why was curettage done?
Doc, ang tawag dito? May curettage done. Because the patient, doc, has case of incomplete abortion. So there is fetal, ano ba yun? Fetal left or ano ba? Ano tawag
There
dito?
are retained
Fetal
product of
retained, yeah,
conception
yes,
left.
doc, retained product of
Okay.
conception.
How much was evacuated or how much was left?
Ah, doc, yung ano, nakuha na lang specimen half lang.
Half lang,
Yes po.
half ng
No. Parang wala pa nasabi doc kung ilan talaga
correct.
yung, yes po.
What am I driving at? For example, left alone, would that have come out? Is there room for medical management?
Doc, yes, doc, but the patient is unstable, doc eh. So,
That should have been your first answer. Why was the patient
yes,
performed? Because there
yes,
was a lot of bleeding
unstable, yes.
initially. Patient's vital signs were unstable. Hence, there was a need to evacuate fast. For example, stable vital signs. Could you have waited and have had medical management done?
Possible po, doc.
How would your medical management be initiated?
We can give doc misoprostol doc.
Misoprostol, is it readily available here?
I think no doc po.
What are your options that are legal?
May evening primrose doc. Charot.
What will evening primrose do?
Partially or dilate the cervix doc. Tama ba?
Oh, nung bumuka na, di ba? Oh, kailangan mo pa ba ng if-frame?
Ay, hindi na doc. Open up po pala.
O,
Open na
open
yung
na.
doc, oxytocin po.
Okay, what are your oxytoxics? Oxytocin, one, oxytoxic of choice. What else?
Hindi na mo isip. Ayun doc. Hindi ko po nabasa iba. Sorry, doc.
You have your methyl ergometrin, your ergo derivatives. What does it do? Metergine. It's one of the friends of your friendly medicines of your OB. So it would induce stomach cramping, uterine contractions, and thereby remove all the retained products of conception that isn't. So take home point for this case, okay? If vital signs are not stable, yes, you're indicated to have your completion curettage. But if your sorry, I'll take this call. I'm sorry. So there. So what we should do, medical curettage or metergine, not all abortion cases you do curettage on. It's an expensive procedure, especially with the pandemic. Now it will cost around 40,000 for an a curettage to be done at the hospital. Okay? So if you could manage medically, it would be a great service to your patient, but still know the indications when you need to do your curettage still. All right?